So what I'm going to talk about now is gonads. I want to make it clear, we're going to talk about gonadal hormones much more when we get to reproductive system. So I can promise that the only gonadal hormone that I will ask about on this exam will be male axis. I'm not going to ask about females, okay? At least, well, like, what is the gonadal hormone in females? It's estrogen. That's it. Not farther than that. So, gonadal hormones are the part of HPG axis, hypothalamus, pituitary, gonadal axis. And there's not a particular stimulus to their production. Okay, you can't sort of by stimulation through, I don't know, eating something or experiencing some emotion start accidentally making more testosterone. So what happens is this. A hypothalamus releases gonadotropin stimulating, a gonadotropin releasing hormone. GnRH, gonadotropin releasing hormone. That makes sense. So this gonadotropin releasing hormone stimulates anterior pituitary gland to release gonadotropins. Now remember what I mentioned about the term tropin. Tropin basically means a place where it goes, right? So gonadotropins, they go to gonads. And here's what happens. So you produce, all of us here, we produce two types of gonadotropins, luteinizing hormone and follicle stimulating hormone. Okay? Now, I told you it's going to be males, but I'm just going to ask you, for the sake of the question, what do you think, listen to the name, follicle stimulating hormone does? Huh? No, not real. No, different follicles. No. Okay, but it stimulates follicles. That's it. So, it's named after female follicles. Follicles in the ovaries. It stimulates the growth of follicles in the ovaries. Does that make sense? In males, the analog to follicles, to follicular development and the development of the oocyte in males, is going to be development of a sperm cell. Does that make sense? So, FSH acts on testes, which results in spermatogenesis. So far makes sense? We good? Okay, spermatogenesis. Luteinizing hormone also acts on testes, and in males it results in the release of testosterone. We good so far? And testosterone actually is essential for proper spermatogenesis. Are you following me? We good?
FSH targeted parietal cells. I thought FSH targeted parietal cells.
In
I don't know.
no. It targets certain cells in a testis called Sertoli cells. But it's like we're not talking about Sertoli versus Leydig cells now.
Okay.
What you need to know right at this point, FSH in males stimulates the development of sperm cells, which is impossible without testosterone. That is stimulated by LH. This is why you need two of them. Does that make sense, that part? Good. So, as with any axis, we need to establish a negative feedback loop, right? So there are two hormones that establish that negative feedback loop. One of them is testosterone. Okay? And hypothalamus to an extent. But so basically at this level, what I want you to know, testosterone inhibits hypothalamus and pituitary from releasing gonadotropins. Does that make sense? We clear so far? And another hormone is inhibin. Okay? Are you with me? Inhibin is produced overall by testes. And it's not a result of FSH or LH stimulation. You just put it on the opposite side. Are you with me on this part? We're good? I'm going to ask a couple of questions, actually. I love this topic because it really, really shows you, first of all, there is no stimulus. There really isn't. There's some like background release of gonadotropin releasing hormone. Does that make sense? Which stimulates your ABG, which stimulates your LH and FSH. Well, okay, let me use myself as an example. So it stimulates my LH and FSH, which act on my testes, which stimulates my spermatogenesis. Now, testosterone inhibition is important because if there would be no inhibition, basically the amount of sperm that a male would produce would be absolutely astounding. It is astounding at millions of cells, right? But it just, we wouldn't be able to handle it. Nutritionally, anatomically, wouldn't be. Does that make sense to you? Now a couple of questions. Question number one. Actually, the only one. Imagine that a person, an athlete, starts taking testosterone. It's an anabolic steroid. We all know testosterone not only stimulates spermatogenesis, why boys change so much during puberty, because testosterone spikes and it stimulates the muscle growth and the bone growth and the facial hair and so on and so forth, right? So what if somebody takes testosterone, exogenous testosterone, IV? How that exogenous testosterone will affect the levels of luteinizing hormone and FSH?
It would decrease them.
Yes, it would decrease them. Does that make sense? You take testosterone and these hormones go down, right? So if FSH goes down, how's it going to affect the spermatogenesis?
Also,
Yeah, it will decrease spermatogenesis. Now, think of these two hormones as something that constantly stimulates testes. With the lower levels of gonadotropins, the lack of stimulation, hormonal stimulation of testes, will result in shrinkage. If you will look, well, I'm not suggesting you will, but if you would look at bodybuilders from the very early era who were taking testosterone, their balls literally shrunk because of this effect. And infertility is a very common side effect of testosterone utilization as the PED, performance enhancement drug. Does it make sense? But maybe even more elegant regulatory loop here is through the inhibin. So the amount of inhibin that is produced depends on the amount of sperm that is stored. Because males produce sperm all the time. And those sperm cells, they feel a really, really convoluted network of tubules. Does that make sense? And sperm cells mature there. So, when sperm cells accumulate more and more, levels of inhibin increase. Are you following me? Which kind of suppresses this whole axis and reduces spermatogenesis. Does that make sense? After the ejaculation in males, the levels of sperm cells, the amount of sperm in the testicles decreases. Does that make sense? Which means the amount of inhibin decreases. Which means this axis reinvigorates. More sperm cells are produced when they go to sort of kind of a cap, drives it down. Does that make sense? So the only thing that you need to know about the females, really, is that Spermatogenesis, you can basically replace with oogenesis, so oocytes. Testosterone with estrogen. The cycle is totally different. Not totally, but very much different. Because in females, there's an ovulation step. Does that make sense? And the connections between hormones are very different. We are not tapping into this. It's just too large, and I don't think it's worth it doing it now. I keep it for reproductive. For now, like estrogen and oocytes. Are we clear? Any questions on this one? Go ahead.
You said there was no stimulus, so does puberty act on like a like would puberty not be a stimulus for this? Or like age?
It will be, so that's a really good question. Puberty is the result of increased activity of the axis. So I do not know, I'll be honest, I do not know how GnRH levels change in puberty. My hunch would be that it increases. Because if you look at and the whole activity of this thing increases. Because if you look at the dynamics of the testosterone levels in a male with age, it goes very low until puberty, whenever it is. Then it goes up, and it stays relatively high throughout life. Which actually brings us to one interesting story. You may have heard at some point there were really popular prescription drugs, like testosterone sticks, like testosterone. Basically, you apply, it's like a deodorant stick. So you apply into your axillary region, so it doesn't go on like open skin, and testosterone would be absorbed, because it was a common myth that in older men, like 50 plus, not really older, but 50 plus, testosterone levels go down. Well, they do go down, but first of all, use of those prescription drugs did not improve the quality of life, because people were like, oh, I'm sluggish, I cannot work out, I'm getting fat. It's always easy to blame endocrine system for that. So, studies showed no improvement in the quality of life. And what's horrible, some men with prostate cancer were prescribed those testosterone treatments, and testosterone accelerates the growth of prostate cancer. It was really poorly executed story. It was just basically a moneymaker, and it very quickly shut down. Thankfully, because, evidence-based medicine. Any questions about this part? I'm going to slap one little thing that I forgot to mention last week. Basically, I'm telling you 3 ways of sort of hormonal stimulation. Nervous, humoral, and hormonal. Let me explain what I mean. Since now you know all main hormones, look, when you are stressed and your hypothalamus produces corticotropin releasing hormone, CRH, that's an example of nervous stimulation. Does that make sense? We clear? When you have change in your extracellular fluid, let's say you have high glucose, low glucose, dehydration, things like that, and you produce insulin or glucagon or ADH, that's humoral stimulus. Does that make sense? And when gonadotropin releasing hormone stimulates the release of gonadotropins, this is hormonal stimulation. So basically what I'm getting at, I can ask you, which of the following is an example of humoral stimulation of hormone release, or nervous stimulation of hormone release, or hormonal? And I give you 4, 5 scenarios, and you pick one. Am I clear? Any questions?
Can you go over the hormonal one again?
Sure. So, for instance, here, gonadotropin-releasing hormone stimulates the release of two other hormones. That's all. Basically, any axis has plenty of examples. We good? Any questions? No? Okay, let's take a break.